Hi, I'm Judith Michels, a medical oncology in gynecological oncology at Gustave Roussy, leading cancer center in Europe, based in France. HPV is the most common sexually transmitted infection with approximately 200 genotypes. 12 have an oncogenic potential. HPV-16 is the most common. And high-risk HPV cause 5% of all cancers worldwide, with an estimated new cases of 690,000 per year. 90% of them occur in women. And cervical cancer is the most common HPV-related cancer in the world. Those proportions vary among the income group. They are the highest in low-income countries. In high-income countries, the proportion of anal and head and neck cancer is higher than in low-income countries. And in particular in men, the oral HPV infection is a necessary cause of a dramatic and ongoing increase of oropharyngeal cancer incidence, largely among men in numerous countries worldwide. And the prevalence of HPV in oropharyngeal cancers is approximately 70%. Survival rates vary with cancer type and tumor stage. The prognosis of patients with distant lesions is poor and worst in penile cancer, with a 5-year relative survival rate of 9% for penile cancer, of 17% for cervical cancer, of 34% for anal cancer, and of 40% for oropharyngeal cancers. For cervical cancer, the incorporation of the anti-VEGF agent bevacizumab has been able to extend overall survival beyond 12 months. For anal cancer, the first-line treatment is chemotherapy based on carboplatin and paclitaxel. For head and neck oropharyngeal cancers, the first-line treatment is pembrolizumab, either as a monotherapy or combined with chemotherapy for PD-L1 positive tumors. And in Europe, for PD-L1 negative tumors, the chemotherapy in combination with cetuximab remains a standard of treatment. There are limited available treatment options for metastatic patients with HPV-related cancers. For cervical cancer, the first-line treatment is chemotherapy plus bevacizumab, with a median overall survival up to 16 months. In Europe, there is currently not yet a second-line standard treatment. In the US, for PD-L1 positive and MSI or MMR deficient tumors, pembrolizumab is a standard option, with a median overall survival of 9 months. For anal cancer, the standard first-line treatment is chemotherapy. For carboplatin and paclitaxel, the median overall survival of 20 months. The standard second-line treatment is immunotherapy. For head and neck, HPV-related head and neck tumors, the first-line treatment is immunotherapy, pembrolizumab, either as a monotherapy according to the PD-L1 status or in combination with the chemotherapy, with a median overall survival of up to 14 months. And the chemotherapy in combination with cetuximab remains a standard in Europe for PD-L1 negative tumors. The second line treatment is immunotherapy for patients that have been treated with chemotherapy as a first line. Given those results and median overall survival, there is an urgent need for more effective treatments in metastatic HPV-related cancers. We would like to be able to cure HPV-related cancers. Even better, we could eradicate it. There is an available preventive HPV vaccination that has shown the efficacy to reduce the risk of invasive HPV-related cancers. A Swedish survey over 10 years in 1.6 million women aged 10 to 30 years, the vaccination has proven to reduce the risk of invasive cervical cancers by twice if the women are vaccinated after 17 years, and by 10 times if women are vaccinated as early before 17 years. In countries like Australia that know a high coverage vaccination in male and female above 70%, they estimate that they could reduce the incidence in 20 years below 4 cases per 100,000 persons, and in 40 years below 1 case per 100,000 persons. The detection of HPV is vital, in particular for oropharyngeal cancers. And currently, the most promising technique is the RNA in situ hybridization, since the transcriptional activity is determinant for the clinically and biologically relevance of the detection of HPV. The P16 protein staining by immunohistochemistry is a surrogate marker that can be used in oropharyngeal cancers to detect HPV. The DNA can also be detected by PCR, and those techniques can be evaluated, of course, on tissue specimens, but also on fine needle aspiration biopsies, on serum, on saliva. Other techniques like antibody detection and HPV DNA are developed. There is a need for more effective treatments in metastatic HPV-related cancers. And the immunotherapy will change the fate of this viral-induced cancer in the near future. And the new treatment options like antibody drug conjugates, like bifunctional fusion proteins, like adoptive T-cell therapies, are promising for our patients. Thank you for your attention.
My name is Andy Sikora. I'm a professor of surgery in the Department of Head and Neck Surgery at MD Anderson Cancer Center in Houston. I'm a tumor immunologist as well as a head and neck surgeon. So when we talk about HPV, we're talking about multiple different strains of the virus. About 14 of those are what we call high-risk HPV strains. These are the ones that are most likely to lead to cancer. And of those 14, there's 2, HPV-16 and HPV-18, that cause the majority of HPV-related cancers. For the cancer of greatest interest to me, oropharynx cancer that's caused by HPV, HPV-16 is by far the most common type. So as a virus, HPV is adept at evading the immune system and avoiding immune destruction. So we know that the HPV virus, once it gets into the epithelial cells, expresses proteins, so-called early proteins and late proteins. The early proteins, which are involved in modulating the tumor cell cycle or the epithelial cell cycle, as well as immune suppression of those proteins. Probably E6 and E7 are the best known. E6 is known to interact with P53 within the infected cell. E7 interacts with RB. Both of these act to dysregulate the cell cycle and drive unregulated proliferation in the cell, but they also have direct effects on cell signaling and direct immune suppressive effects, as do other viral proteins as well. And these immunosuppressive properties affect both the innate and the adaptive sides of the immune system. For example, they suppress the sensing of the innate immune system and production of immune activating cytokines. They suppress signaling by immune activating cytokines, particularly the type 1 interferon response that is so important to early antiviral immune responses. They're able to suppress the production of immune stimulatory cytokines and soluble factors by suppressing NF-kappa B signaling. And they're also able to help tumor cells sort of become invisible to the adaptive side of the immune system by suppressing antigen presentation by class 1 MHC cells. So you can imagine that the microenvironment of these cancers is very complex and differs between HPV positive and HPV negative tumors. Something that both HPV positive and HPV negative tumors share, at least in the case of head and neck squamous cell carcinoma, is a very immune suppressive microenvironment in general. So you can imagine that the this microenvironment is sort of like a protective shell that the tumor cells create to protect them from, among other things, immune attack and immune surveillance. This microenvironment is carefully crafted to include very high levels of immune suppressive cells, chemokines, cytokines, and other molecules. And it supports the progression of the tumor as well by not only shielding the cancer from immune attack, but also by creating an environment that basically is highly adapted to its growth. That brings in, blood vessels, that brings in the nutrients it needs. And most importantly, perhaps in the case of HPV-related cancers, which of course, contain those viral antigens that could potentially be recognized by the immune system, it's a very immune suppressive microenvironment that includes things like T regulatory cells, like immunosuppressive myeloid cells, and these immune suppressive cytokines that are able to damp down the immune response, including tumor growth factor beta or TGF-beta, TNF-alpha, interleukin-10, IL-6, and then other immune suppressive and inflammatory cytokines. So TGF-beta actually plays a dual role in the establishment of epithelial cancers, including head and neck cancer. Early on in cancer development, it actually plays an inhibitory role, something that we've learned from a lot of preclinical studies using transgenic and knockout mice, where by altering TGF-beta signaling, you can actually modulate the development of epithelial cancers in these model systems. And we know that early on in development, TGF-beta tends to be anti-proliferative. It tends to be something that prevents the tumor cell from progressing. However, as the tumor and its microenvironment, in a way ripen and become increasingly more established as an invasive cancer, there's sort of a switch that flips, and TGF-beta begins to play a pro-tumor role, both in terms of the modulation of the immune system and creating a suppressive immune microenvironment to enhance the tumor growth, but then also directly deriving cell-intrinsic tumor growth and oncogenic pathways that help epithelial cancers become established, to progress, and ultimately to become established as solid tumors. So TGF-beta affects both the innate and the adaptive arms of the immune system. With respect to innate immune cells, it alters the function and the development of myeloid cells, including both dendritic cells. These are professional antigen-presenting cells that are necessary to initiate a productive anti-tumor immune response, and which can be inactivated or skewed towards an immune suppressive phenotype by TGF-beta. TGF-beta also has significant effects on the macrophage population, particularly the tumor-infiltrating macrophages, or so-called M2 or tumor-polarized macrophages that play an immune suppressive role within the tumor microenvironment. And a third innate immune cell type that is affected by TGF-beta is, of course, the natural killer cell. These are cells that primarily play a role in lysing epithelial cells in the tumor microenvironment that have downregulated major histocompatibility molecules to become invisible to the immune system. And these NK cells are inactivated by TGF-beta as well. With respect to the adaptive immune system, TGF-beta is probably best known as a modulator of CD4 positive T cell function. It affects the development and the differentiation of CD4 positive T cells from an effector phenotype into either a regulatory phenotype, so-called Tregs. These are T cells that suppress the function of effector T cells, and TGF-beta also skews CD4 positive T cells towards the so-called Th17 or inflammatory T cell phenotype. In some cases, Th17 cells can have anti-tumor activity, but overall, in the context of HPV-related head and neck cancer, it seems that they play an immune suppressive role. Finally, TGF-beta also has direct effects on effector cells and inhibits many of the effector functions of these cells that are necessary for tumor recognition and killing. So as you can imagine, TGF-beta is a critical signaling pathway that is dysregulated in many different types of cancers, including head and neck cancer, and of course, including HPV-related head and neck cancers, the topic of this conversation. We know that when TGF-beta levels are high, this is associated with poorer prognosis in, again, many cancers, but this has been shown in oropharyngeal cancer as well. Interestingly, high TGF-beta expression has also been shown to be associated with a microenvironment phenotype of head and neck cancer that we call the immune desert. These are the cells that have very few immune cells in them and respond poorly to immunotherapy and have poor prognosis, poor survival, well. This is associated with upregulation of TGF-beta signaling in these tumors. It's also been shown that levels of TGF-beta can be a biomarker of resistance to cetuximab. So there's a study that shows that in patients with higher levels of TGF-beta expression in the tumors, they had overall poorer response to cetuximab. And all of these factors, plus what we know from a biological standpoint of the critical role of TGF-beta as both a mediator of cell-intrinsic tumor growth and progression, as well as a master, immunomodulator driving immune suppression. This makes it a very attractive target for drug development and therapy.
My name's Krish Tiwari. I'm a gynecologic oncologist at the University of California, Irvine, where I'm the division director, and I hold the Philip J. Desai Endowed Chair in Gynecologic Oncology. Excellent question. As you know, we have quite a few HPV-associated cancers these days. The traditional one, of course, is the one that I work with, cervical cancer, but anal cancers and at least a third of the oropharyngeal cancers are mediated by HPV or associated with high-risk HPV infection. And we have learned through many different phase 3 and now phase 3 randomized trials that the immune checkpoint inhibitors, specifically those that block PD-1, are effective in treating many of these cancers. And here we can see in this slide current NCCN guidelines for cervical cancer. Pembrolizumab has been approved in the second-line setting for patients whose tumors express PD-L1 on the tumor, as well as through the agnostic indication, microsatellite instability high or mismatch repair deficient tumors. In anal cancer, both nivolumab and pembrolizumab have been approved or are recommended by the NCCN. And for squamous cell carcinoma of the head and neck, first-line pembrolizumab with chemotherapy or pembrolizumab monotherapy if, again, the patient has a CPS score of 1 or greater for PD-L1 expression. And then, as you can also see, second-line nivolumab or pembrolizumab is approved in squamous cell carcinoma of the head and neck, as long as those drugs had not been reused previously. Here's this is a nice summary of the checkpoint inhibitors and where we're going. The Empower Cervix 1 study was a randomized trial of cemiplimab versus single-agent chemotherapy, investigator's choice. It was recently reported that this physician's choice chemotherapy did not perform as well as cemiplimab. Cemiplimab significantly improved overall survival in the squamous cell carcinoma cohort, with a median overall survival of 11.1 months with cemiplimab versus 8.8 months with investigator's choice chemotherapy. We got the phase 2 study of balstilimab that was reported at ESMO a year ago in 2020. Objective responses were 15% in the second-line setting. The phase 2 trial of balstilimab alone or in combination with zalifrelimab, which is a CTLA-4 inhibitor in this space, was also important. And again, we saw responses in not only patients that express PD-L1, but also those who did not express it. And we have confirmatory trials in development for these two drugs. And then, of course, the Keynote 826 study was the subject of a press release earlier this year, just a few months ago, where it was reported that the combination of chemotherapy plus pembrolizumab, with or without bevacizumab, significantly improved both overall survival and progression-free survival. These are some non-cervical cancer ongoing trials using checkpoint inhibitors. We've got studies looking at PD-1 and CTLA-4 combinations in anal cancer. I think this strategy is very important because for PD-1 inhibitors to work, we need a lot of CD8 positive T cells in the tumor microenvironment, and CTLA-4 blockade brings those T cells into the tumor microenvironment so PD-1 inhibitors can work. In the head and neck space, we've got, again, that same type of combination being explored, PD-1 and CTLA-4, but we've also got other checkpoints being studied as monotherapies. Durvalumab, monalizumab are two examples. And what's nice about in the head and neck space, they're being studied earlier in the disease process where the patients are diagnosed with locally advanced disease and are typically treated with chemoradiation. This is the idea here, and the theme is to add checkpoints to chemoradiation. Yeah, the data is evolving with TGF-beta, and fortunately, we have a very novel drug that I'll be talking about in a second that targets it. But the key thing to understand with TGF-beta, it's part of a superfamily, the transforming growth factor superfamily, that is very immunosuppressive. So we have a new pathway in addition to the PD-1, PD-L1 axis to target in our immunotherapies. The drug I wanted to mention, where most of this data is emerging, is called bintrafusp alpha. It's a bifunctional antibody that binds not only PD-1, but also binds TGF-beta. So it blocks both the PD-1 axis and the TGF-beta axis. And we've had studies in cervix cancer that were immune checkpoint naive, where we saw objective responses as high as 27% in a cohort of 39 patients. About a fifth of the patients did have grade 3 or above treatment emergent adverse events. In a basket trial looking at cervical cancer patients, along with anal cancer, vaginal cancer, rectal cancer, and head and neck squamous cell cancer, this same drug was able to affect an objective response of 30.5% in a checkpoint naive cohort. And grade 3 and 4 adverse events, close to a third of the patients, are 27%. And then we do have ongoing phase 1 studies that are starting to report for head and neck cancer, specifically patients with heavily pretreated esophageal cancer treated with bintrafusp alpha, objective response rate of 10%, which is remarkable. And I've been waiting for therapeutic HPV-directed vaccines to have a presence in the field, and I think this is the year where it's really coming to a forefront. We have no less than 5 very unique therapeutic vaccines for HPV-associated disease. You can see them; they're all listed in this table that nicely summarizes the phase 2 studies that have recently been completed. PDS-0101 is a HPV-specific vaccine that's based on liposomal packaging. IO457 is a vaccine that is derived using a plasmid. ISA-101 is a therapeutic vaccine that's HPV specific using long synthetic peptides. We also have the novel gorilla adenovirus that's used as a vector to deliver HPV E6, E7 oncogenes to get an antigenic response. And then UCP-Vax, that's the 5th vaccine that you can see on this table. And interestingly, this is not specific for HPV, but what it does is it uses a telomerase to take advantage of the universal cancer proteins that are present on many of these HPV-specific cancers. All of these vaccines you can see are being combined with checkpoint inhibitors, as well as PDS-0101 is being combined with bintrafusp alpha, which has checkpoint activity in that it's dual function targeting not just TGF-beta, but also PD-1. So these studies are really proof of concepts of not just therapeutic HPV-directed vaccines, but also combinatorial therapy of therapeutic vaccines with checkpoint inhibitors. Yeah, T-cell-based therapy, or specifically tumor-infiltrating lymphocytes, was actually the first immunotherapies that were really being studied in cervical cancer. So before we got accelerated approval for pembrolizumab for its second-line recurrent setting, TILs was being studied at the National Cancer Institute. Basically, the technology involves cutting out a piece of the tumor, whether interventional radiology-guided biopsy, a biopsy using through the vagina using a speculum, or laparoscopic surgery, getting a piece of the tumor, isolating the T cells, expanding the T cells, or growing them up, if you would, and then using myeloablative therapy that's usually IL-2 based to kind of condition the patient's bone marrow, and then reinfuse the patient with a single dose of the tumor-infiltrating lymphocytes. And this is known as adoptive immunotherapy or adoptive T-cell therapy, and the results so far have been remarkable. Here we have the data from Christian Henrich's work at the NCI. I mentioned that the original study was being done there. Dr. Stefanovic published this data in 2015 in the Journal of Clinical Oncology. And what was remarkable about this cohort of 9 patients that they treated, these were all women with metastatic recurrent cervical cancer, and they'd all been heavily pretreated. Nothing was working. They went to the NCI. There was funding to bring them there. They underwent surgical biopsy. The T cells were isolated, expanded, and a single dose of TIL infusion resulted in 2 patients having complete responses to TIL's infusion that lasted a minimum of 15 and 22 months after the infusion. And this was, the 15 and 22 months was around the time when the paper was published. And this was very exciting. Since that time, there is a lot of work being done currently to try to bring this technology out into community practice so patients don't have to travel to the National Cancer Institute to have this done. But it's a HPV specific directed therapy, as Dr. Hendricks showed by using their assays to look at E6 and E7 reactivity. The patients who responded to TILS therapy also showed reactivity to these oncoproteins. Combinations seem to be the way to go, with the Keynote 826 study showing that both progression-free survival and overall survival were significantly improved when pembrolizumab was added to chemotherapy with or without bevacizumab. You've got the blueprint right there, or the foundations for combinatorial therapy. And then any one of those phase 1 or phase 2 studies that were on that previous slide that combined therapeutic vaccines with checkpoint inhibitors is probably going to be the way forward. And of course, ideally we don't want to bring patients into the clinic when they've got recurrent or metastatic disease. Ideally, we want to get them earlier. So these studies that are looking at adding checkpoint inhibitors to patients with locally advanced disease, whether it's cervical cancer or head and neck squamous cell carcinoma, those are the studies that we really want to pay the most attention to, because that combination of chemoradiation plus checkpoint, maybe even with or without a therapeutic vaccine, this is the way we're going to cure most patients with who present with stage 3 disease. At least that's what I hope.